Hi everyone. This is a training presentation for HCA Florida West Hospital. It is about hypertension and pregnancy, and this is for all units that manage antepartum, intrapartum, and postpartum patients. We are specifically discussing preeclampsia with severe features. Uh, when our patients come into the ER, especially our pregnant patients, and they start showing any of these symptoms, it is very important that we quickly get these patients treated. On assessment, we'll be seeing headache, visual changes, right upper quadrant pain or epigastric pain, nausea, vomiting, general malaise, protein in the urine. But the key one that we really want to focus on is blood pressure. A couple others are significant recent weight gain. Uh, we want to be assessing their lung sounds for crackles, signs of fluid overload, which is a late sign of the preeclampsia, and differences in our deep tendon reflexes. Some more severe features of preeclampsia indicating medical emergencies are systolic blood pressure greater than or equal to 160, or a diastolic blood pressure greater than or equal to 110. Please note this is very different from just any other patient that walks into the ER or on our units, where we normally don't treat until 170. For pregnant patients, we are treating our blood pressures much earlier. A couple other late features of preeclampsia is thrombocytopenia or a platelet count less than 100,000, impaired liver function, our labs coming back at 2 times the normal limit, epigastric pain right upper quadrant pain, renal insufficiency with a creatinine greater than 1.1 milligrams per deciliter, oliguria with our patients making less than 500 milliliters of urine in 24 hours, cerebral or visual disturbances, specifically a headache unrelieved by Tylenol or other medications, and a very late sign of preeclampsia, which means this patient will be heading to the ICU, is pulmonary edema. One other major thing to note, we are specifically talking about preeclampsia, but if we get to eclampsia, the main difference between the two is the presence of seizures in a pregnant or postpartum patient without a neurological cause or other etiology. This is not the mother who hasn't taken her seizure medications and had a seizure. This isn't the mother who may have had a stroke or is found to have a brain tumor or something else that can cause a seizure. This is specifically for pregnant people without any other cause of a seizure having a seizure and hypertension. The main item we are focusing on with our preeclampsia patients is taking and measuring blood pressure and frequently monitoring it. A couple key things in review of taking an appropriate blood pressure is making sure that we take the measurement 5-10 minutes after the patient has sat down. We need to give them a few minutes to relax. If we are having them do a whole lot of activity, or we're taking it as soon as they get to the room after walking through the hospital trying to get to us, it can be falsely elevated. Make sure we're using the right size cuff. If we are using the cuff that's too big, we might get an inaccurately low pressure reading. If we are using the small cuff on a larger patient, we may be getting a false high. Also, make sure the blood pressure cuff is at the level of the heart. Take the blood pressure reading in an upright position if possible. Make sure that the patient does not have their legs crossed, is sitting there nice and relaxed. And for our repeat measurement, we want the patient to be in the same position, and we want it to be within 15 minutes of the initial measurement. The key thing for preeclampsia is we have to have 2 high blood pressure, whether systolic greater than 160 or diastolic greater than 110 readings within 20 minutes of each other. For our treatment of preeclampsia, we have four main medications. They are listed in preference order. Our physicians want labetalol IV as our first line drug, hydralazine IV as our second line, nifedipine PO, or if those have been ineffective, we want to use our nicardipine drip. We must administer some form of antihypertensive medication within 20 minutes of the second high blood pressure. Now that we have talked about preeclampsia and have introduced our drugs, let's take a closer look at each drug individually. So our first drug that we want to use is labetalol. It is our drug of choice. You can see up in the comment box up here where it says avoid labetalol in women with asthma, heart disease, or congestive heart failure. These are some potential contraindications to it. The physician will determine if this is a reason to hold it or if we should still continue to administer the labetalol. The big thing that we must be checking is our heart rate. If our heart rate is greater than 60 beats per minute, we can give this medication. As you can see with the first box, we'll be administering labetalol 20 milligrams IV over 2 minutes. We then reassess our blood pressure 10 minutes after the dose. If our systolic is still greater than 160 or greater than 110, we're going to administer labetalol 40 milligrams over 2 minutes. 10 minutes later, we reassess our blood pressure. If we are still high, note how we administer labetalol 80 milligrams IV over 2 minutes. Then we repeat our blood pressure 10 minutes later. If we are still high, we then begin administering hydralazine. And in this labetalol algorithm, it goes right into the hydralazine, 10 milligrams IV over 2 minutes. And then repeat the blood pressure 20 minutes after dose. If our blood pressure is still high at this point, we need to be contacting our OB provider and getting an emergency consult from anesthesia, our hospitalists, or our critical care docs. If the labetalol does not work, we again will go to our next algorithm, which is hydralazine. Similar to our labetalol algorithm, we have our hydralazine algorithm. If our heart rate is less than 60 on a patient, we can't use the labetalol algorithm, so we would come to the hydralazine as our second line drug. And we see how we give hydralazine 5 milligrams over 2 minutes, repeat blood pressure 20 minutes after dose. That's one difference, is the time frame between reassessing after administration. If our blood pressure is still high, we administer hydralazine 10 milligrams over 2 minutes. Wait 20 minutes, repeat our blood pressure. And then if that hydralazine has not worked, we would then consider going back to our labetalol. One big note here is if we have already used our labetalol algorithm, we are not going to be going back to our labetalol algorithm. We will be looking at our third or fourth line drugs. Oral nifedipine. This is not our first line drug of choice. This is really only used in one main situation. If we cannot get an IV access quickly, or if obtaining an IV access will cause the medication to be administered in greater than 20 minutes. Our administration of nifedipine, another key factor is it is the immediate release. And we start with 10 milligrams orally. We repeat our blood pressure 20 minutes after the dose, and then we would administer a second dose of nifedipine at 20 milligrams. Repeat our blood pressure 20 minutes after we give that dose, and then we can give a second dose of nifedipine, 20 milligrams. If the nifedipine has not worked, we can use our other algorithms because during this time we should have been able to obtain our IV access. For an cardiopine algorithm, this is used if all other medications have failed to control our blood pressure. Uh, we must have telemetry going without exception. And if we are administering cardine, we really should be evaluating the patient for a higher level of care, whether it's PCU or ICU. Once we get the cardine running, we're repeating our blood pressures every 15 minutes and titrating our medication um, to our maximum dose of 15 milligrams an hour per our physician orders so that we can get our blood pressure taken care of. I just briefly want to touch on our eclampsia seizure algorithm. If our patients do go from preeclampsia to eclampsia, this is our flow chart of what we should be doing: calling for help, maintaining our airway, our ABCs, keeping our patients safe, and making sure that we get our OB team, our ICU team, whoever we have available in to help. A couple of the big things is giving magnesium sulfate. This in this situation becomes a critical drip. We are giving 4 to 6 grams magnesium over 20 minutes, and then we are starting a maintenance dose of 2 grams. If a patient does not have IV access by this time, we would be giving 10 grams mag sulfate IM, 5 grams in each buttock, and we need to start an IV immediately. If we can't get IV access, we need to consider central line or IO in the meantime. After, you can see where we start our post-seizure care. And if we have a recurrent seizure, we consider giving more magnesium. And if the magnesium after our second dose has not worked, we would then consider our benzos, our Ativan, our diazepam to take care of the seizures. For our eclampsia algorithm, we briefly touched on mag sulfate, but we can use that for preeclampsia as well. Per our physician guidelines, we give it to help reduce the risk of seizures. At the doses we are giving it, this is a critical drip and requires 2 RN check. We have our loading dose of 4 to 6 grams IV over 15 to 30 minutes, and our maintenance dose of 2 grams per hour. Before we even start giving our magnesium, we need to check deep tendon reflexes so we have our baseline. And we also need to review mag toxicity of new onset loss of deep tendon reflexes, respiratory depression, shortness of breath, or respiratory arrest, decreased responsiveness, chest pain, ECG changes. A couple normal symptoms that we need to review with the patients as we are giving the magnesium bolus is a flushed feeling, sweating, just generalized feeling of warmth all over. That is normal. If we are giving magnesium, we need to also look at calcium gluconate. It is the antidote for magnesium toxicity. We must have calcium gluconate ordered and readily available. Keep it at your bedside for all patients receiving mag sulfate, because if they start having any of the symptoms of toxicity, we need to be able to give our calcium quickly to reverse those symptoms. And it is a 10% of calcium gluconate, the 1 gram, over 2 to 5 minutes for the antidote. Just a couple key points on the preeclampsia treatment. Accurate assessment of blood pressure is vital to successful treatment. If we are not able to accurately measure our blood pressure and we do not successfully reassess our blood pressure within the 15-minute time frame, we can't take care of our patients the way that we're supposed to. Also, our medication doses are different than the normal doses we would normally see on the floors. Some of the doses are significantly higher than what on the floors we would normally give. Minimizing the time to treatment is essential. First medication dose should be given no more than 20 minutes after the second high blood pressure. Sometimes the doctor will order the protocol, order the medications. It takes a while. We may need to call pharmacy to expedite being able to give the medication, scan it in. And if that is taking a long time, we may need to consider overriding a medication from the Pyxis, having a second RN with us to verify the medication in the room and verify that the order is in, just not verified, and giving the medication. The other very important thing that we need to know is anytime we have a blood pressure that is elevated, systolic greater than 160 or diastolic greater than 110, we need to be letting our physician know. That way we can make sure that we're getting the appropriate treatment for our patients. Thank you for listening to this presentation. If you have any questions, you can reach out to Alexander Teamy in the ICU or Krista Allen from Labor and Delivery.